And this here is the third in our series of lectures regarding aortic regurgitation. With this lecture here, we'll explore the expected findings when we have significant aortic regurgitation. We'll review some of the surgical corrective procedures that can be performed. And then we'll come along to understand and explore the use of qualitative and quantitative methods for assessing severity of aortic regurgitation. Not only is the calculated regurgitant volume significant, but we also see changes with flow profiles with significant aortic regurgitation. The forward flow through the valve has increased intensity due to more red blood cells moving, creating a greater Doppler shift. The maximum velocity of flow through the valve is increased, and the duration of flow may increase also. Then we may consider the flow profile of the regurgitant jet. Is the signal of the regurgitant jet similar intensity to the forward flow? Is there a rapid pressure equalization and a change to the shape of the profile? Are there secondary flow reversal patterns seen in the aorta? Then there are also 2D findings, such as the left atrium and left ventricle being dilated. And is the left ventricular systolic function hyperdynamic to compensate for the additional volume that must be moved forward? Premature opening of the aortic valve may also be observed. Increased volume in the left ventricle as a result of receiving aortic regurgitation leads to increased pressure, which overcomes the aortic pressure quickly. More so, the end diastolic aortic pressure may also be low. Premature mitral valve closure may also be seen, given the rapid pressure equalization that will be achieved between the left atrium and left ventricle in the presence of significant aortic regurgitation. LV compliance also plays an effect. It's a measure of how willing the ventricle is to stretch to receive an incoming volume. Typically, this is of importance for LV diastolic function, which indicates a non-compliant ventricle. This means a little volume entering into the left ventricle leads to significant pressure rise. This then is termed moderate diastolic dysfunction, which would progress to severe diastolic dysfunction, which is a marked decrease in compliance. The same principle applies to aortic regurgitation. A non-compliant ventricle will rise in pressure quickly and thus terminate the aortic regurgitation quickly. So the AR will appear much less impressive. When we look at our diagram here, we're actually measuring the deceleration time of the aortic regurgitation. A nice long slope typically shows is mild to moderate regurgitation. We have a very steep slope. We're suggesting that we've actually got severe aortic regurgitation due to that rapid pressure equalization. And in this instance here, we can see the early closure of the mitral valve. Again, an indicator potentially of significant aortic regurgitation. So when it comes to corrective procedures, we don't wish to rush into surgery as mortality risk is associated with any of these procedures. Time for surgery is indicated when the patient has significant symptoms that affect quality of life and the echo demonstrates significant LV dysfunction. Other markers include end diastolic and end systolic volumes. When they significantly increase, then surgery is typically indicated. Progressive scans will show the cavity increasing in volume and the LV decreasing in systolic function. There will be a crossover point when the surgeon finds it most appropriate to act. Typical replacements are bioprosthetic valves for those who have not outlived the life expectancy of the valve itself and those who can't tolerate anticoagulation. Prosthetic valves come in varying forms, but as they are foreign bodies and of plastic and metal, they have the probability for thromboembolic events and thus anticoagulation for the patient is necessary. If there are coexisting problems with the aortic root or the ascending aorta, then they are often replaced as well. This may become in the form of an allograft, which is a native valve and ascending aorta, or a Bentel's procedure, where a prosthetic valve is inserted with an aortic conduit. In the image here, we can actually see a three-dimensional representation of a bioprosthetic valve. So again, we can see the struts that protrude out. And the image on the right here, we have a St. Jude's tilting disc. Transcatheter aortic valve implantation may be used. This is typically for frail patients that have higher operative risk or poor outcomes from recovery, and we don't wish for them to actually go and have the surgery, and this is a way we can actually replace the valve. Typically for aortic stenosis, but can also be applied if someone actually developed significant aortic regurgitation. So we can see we actually have the catheter wire that gets introduced. It has the valve scrunched up basically with inside the catheter wire. We place it into position, we inflate with a balloon, and there it sits. Important to note, we can actually see the native valve stays in situ. Assessing regurgitation with colour Doppler is quickly and easily done. There are considerations, however, that one must understand when we make the flow appear more or less severe than what is actually present. With a centrally directed jet, a process called entrainment often occurs. Red blood cells are not moving or associated with the aortic regurgitant jet are dragged into the flow. These blood cells also create a Doppler shift and so broaden the size of the original jet. In the case of an eccentric jet, the flow may hit a ventricular wall or the mitral valve and adhere to the structure. In doing so, the flow spreads out and loses intensity quickly. We see that the flow always appears very underwhelming. The duration and size of the AR jet seen estimates severity. It is important to note to have the correct gain and scale settings. Inappropriately high or low settings will make the jet difficult to assess, the severity in some instances not seen at all. Frame rate is also particularly important with colour, as the systems drop frame rates dramatically when colour is turned on. It is important for the user to minimize width and depth of the color box and apply a 2D zoom or suppression of 2D width to raise the frame rate. Basically, the minimum frame rate we want to attain is 20 Hz. Below this, flow is not represented well and playback appears jerky. Plus, some flow may actually be missed completely if it's very, very transient. Frequency may be adjusted on some platforms. Moving the frequency down will increase the Nyquist limit and then minimize the aliasing of fast-moving jets. The receiving chamber size also guides the sonographer. Significant regurgitation leads to dilatation, so we must always assess for volume overload patterns. Continuous wave signal strength or forward flow compared to aortic regurgitant flow is important. When the signals are of similar intensity, then we must consider that the regurgitation is significant. Maximum flow velocity is through the valve, and the duration of flow may be increased when the aortic regurgitation is significant, as normal stroke volume with the addition of the regurgitant volume must be pushed through the valve. Then we must consider the shape of the aortic regurgitant profile. As we've just described, severe regurgitation shows a sharp deceleration shape due to rapid preset equalization. Systolic flow reversal in the proximal descending aorta may be seen. Pulse wave Doppler is applied just distal to the left subclavian artery, and then an end diastolic velocity is measured. A velocity of greater than 25 centimeters per second is significant. Color may show a significant red flash in the end diastole as well. The abdominal aorta may also be observed, but this is only sensitive for assessing severe aortic regurgitation. Color flowing mode may be applied in the parasternal long axis view, and this can be used to demonstrate flow over a period of time and help to estimate severity. LV systolic function should be hyperdynamic when we have severe aortic regurgitation to actually have the proper forward flow. An EF below than 65% suggests LV dysfunction. As we've mentioned, the ventricle needs to push forward a normal stroke volume plus the regurgitant volume. And in our image here, we have a sample volume placed in the proximal descending aorta, and the point of measure is here, end diastolic velocity. The scale's actually been cut off on this one, but this was actually 0.4 meters per second, 40 centimeters per second, so significant aortic regurgitation. And here we have the ascending aorta, the aortic arch, and proximal descending aorta. And here we can actually see a red flow in diastole, blood actually rushing back up to the aortic valve, which indicates significant aortic regurgitation. Then we have quantitative analysis methods. The vena contracta is a measure just distal to the valve as colour flow moves through the orifice. It is important to measure it in early diastole when the flow should be maximal. Jet height to LVRT diameter establishes a simple ratio to indicate severity. Alternatives to this may be taken from the short axis, where instead we measure the jet area to LVRT area. So here the example of measuring the vena contracta, so just as it moved through the valve, and here we can show that we measure the jet height to the LVOT height to establish the ratio. Pressure half time is useful for its simplicity and the fact that it's not influenced by cardiac output states. It's basically the time taken for the pressure to halve from its original value. And as we've mentioned before, the steeper the slope, the greater severity. So in our table here, we can actually look at a number of the features, everything from vena contracta, jet height, jet area, and pressure half times. And then any of the measurements we obtain, we can actually scale from mild through to severe. Our flow calculations revolve around the simple principle of the conservation of mass. Simply put, we refer to what goes in must come out. As we would expect, stroke volume through two cardiac valves should be equal in the absence of a cardiac shunt or regurgitation. In regurgitation, stroke volume through the incompetent valve is increased. It's the sum of the normal stroke volume plus the regurgitant volume that is leaked backwards into that chamber. This then needs to be expelled forward. So, stroke volume of a regurgitant valve is basically the stroke volume through a competent valve plus the regurgitant volume. Working out what the regurgitant volume is, we just need to rearrange our formula to get this. Therefore, it is important that the assessment of a competent valve must not leak. It will skew this value. To do so will significantly distort the calculation and give a result that is invalid. Viewing the calculation that we have here, we can see a larger CV, competent valve, will lead to the regurgitant volume being reduced. So how do we go about calculating regurgitant volumes? So we know that the regurgitant volume is stroke through the leaking valve minus the competent valve. So expanding upon our formulas, cross-section of the aortic valve times the VTI minus the cross-section of the RVOT times the VTI. In this instance, we assume the pulmonary valve to be competent. If the pulmonary valve did leak, we could substitute for another area, say something like the mitral annulus. The tricuspid valve and its annulus is not preferably used due to the difficulty in actually measuring it appropriately and the reproducibility of actually doing that accurately. So this typically can lead to a significant error in our calculation. So putting it all into practice. So we had a mitral annulus diameter of 3.5 centimeters and the VTI worked out to be 8 centimeters. Then we measured our LVOT diameter to be 2 centimeters and the VTI there to be 13.4. So working out the stroke volume through for the mitral valve, we get 60 mils. Working our stroke volume through for the LVOT, we get 70 mils. So it's a simple substitution then. 70 minus 60 gives 10 mils. Of course, there's the limitations and assumptions and considerations we must apply. Our standard stroke volume assumptions that we previously described apply here. The hydraulic formula is based on a uniform volume flow moving in the cylinder, and the assumptions below that are made apply. The cross-section area remains constant during the flow period. The cross-section area is circular in shape. The sample volume position remains unchanged in relation to the surrounding structures, and flow is steady through the cross-sectional area. As we explored earlier, we understand that flow profiles may change during the period of flow. The Cross-sectional area may also change in the period of systole or diastole, and the cross-sectional area is not always circular, and the sample volume used to measure may move, or the heart may move in relation to the sample volume. There is potential error in measuring the diameter which is used to derive the cross-sectional area. A small under or overestimation can have a significant impact on the stroke volume result. The issue may be compounded as two sets of volumes are calculated this way. Prominent errors may also occur with determining the velocity time integral. An ultrasound beam that does not have parallel alignment underestimates the true velocities of the flow. The sample volume may be positioned incorrectly, such as with the right ventricular outflow tract. When too close to the pulmonary valve, there are systolic clicks and flow acceleration as flow converges towards the orifice. Conversely, if it's too far away from the valve, the user will obtain RV systolic flow at the basal level, which is undesirable. For the atrioventricular valves being used as the competent valve in the calculation, some users inappropriately place the sample volume at the leaflet tips rather than the annulus level. Issues may also occur with measuring the VTI tracing. The user may poorly follow the edge, and the user needs to follow the motor velocity for pulse wave in most instances and the leading edge for continuous wave. The Doppler scale may be set too low with flow extending off the screen and some velocities lost or mingled with aliasing velocities in the other direction, or too high, which is a very small representation of flow on the screen, which is then very difficult to accurately measure. Forward stroke volume through another valve can also not leak. The valve must be confident as any regurgitant flow increases the forward stroke volume through this valve. Looking back at the formula, it is seen this will lead to an underestimation of the regurgitant volume. Similarly, an intracardiac shunt will have the same effect. If the valve is measured distal to the shunt, and thus has greater forward stroke volume, again the regurgitant volume calculated will be underestimated. Finally, we must be aware there is beat-to-beat variability. Even with someone that has sinus rhythm, there are slight changes in heart rate and therefore stroke volumes. Multiple tracings are required. In someone with sinus arrhythmia or atrial fibrillation, ventricular bigeminy, and so on, even greater numbers are required to derive a true representation of the average stroke volume. It must be noted, despite the best efforts of a sonographer, that even measuring competent valves, that a regurgitant volume may still be evident. The grading of severity with standard deviations are set at 95% confidence to actually minimize the possibility of a normal valve being classified as anything greater than mild in these calculations. So in summary, corrective procedures come in the form of valve replacements, sometimes with the ascending aorta. The quantitative analysis plays an important part in assessing the severity of aortic regurgitation. There are a number of considerations a sonographer must apply when looking at qualitative analysis. It is the duty of the sonographer to work within the limitations and minimize potential errors. It is the lazy sonographer that only applies color to assess the valve and look for pathology. We really should look at the quantitative and qualitative methods. And in regards to qualitative methods, the sonographer applies them all to the lesion to actually help them diagnose what's going on. So this may include the use of M mode, pulse wave, continuous wave Doppler, and other 2D findings.